Yeah, it's just a meeting of the physicians, but physicians will be in here all day. This is a scientific meeting for patients, families, anyone else. So good morning, everyone. I'm Julie White, and I'm the Patient Services Director here at the Foundation. Today, I'm doing a presentation on Mesothelioma 101, which is basically just some terms that you might hear during talks today. So just going over some basic information. So we're starting with some basic terms. There's three different cell types or histology that are based on the appearance of particular cells that you will get from a biopsy. The first type of cell would be epithelioid. This is the most common cell type. There's in 50 to 70% of all cases, they tend to respond better to treatment. The next cell type would be sarcomatoid. This is found in 7 to 20% of all malignant mesothelioma, and it's a bit more aggressive or resistant to treatment. Last is biphasic or mixed, and this is approximately found in 20 to 30% of malignant mesothelioma, and it's a combination of both epithelioid and sarcomatoid. The pathology report may identify the dominant percentage of which cell type it is. Moving on to staging. There's the TNM system, which stands for tumor node metastasis. The tumor indicates the size of the tumor or deeper tissue involvement. N is node, which indicates regional versus distant nodes involved, lymph nodes, and metastasis indicates that the mesothelioma has spread outside of the region of the primary disease and or to distant organs. So if you put the T and M together, then that gives us the stage, which would be, there's 4 stages, 1, 2, 3, or 4. When you look at peritoneal, you may see PCI, which is peritoneal cancer index. And this is calculated by giving each of the 13 abdominal regions a score from 0, which is no tumor, to 3, which is a tumor greater than 5 centimeters. And a higher score would indicate more widespread and larger tumor. When you add all of these regions, the score can be between 0 and 39, with 39 obviously being the highest. So with staging, this helps to drive the treatment plan. It can decide things like surgery, systemic therapy, combination therapy, or clinical trial eligibility. Looking at some surgical terms that you may want to know. For pleural patients, you might hear PD, which is pleurectomy or decortication. And this is, they call this a lung sparing surgery. This is a surgery that removes the lining from around the affected lung and tumors from the surface of the lung. Then you may hear EPP. EPP is an extrapleural pneumonectomy, and this removes the impacted lung and other structures that are within the chest. For peritoneal, you may hear something called CRS or debulking, and this is a peritoneal mesothelioma surgical procedure, and the goal for this is to remove all the visible tumor from the abdominal cavity. 2 other terms that you might hear would be HIPEC or EPIC. HIPEC is hypothermic intraperitoneal chemotherapy, and this is the more common of the 2, and this is given in the surgical suite directly after the surgery. I'm not going to explain the procedures in detail because all of these things are things that will be discussed by the physicians. I'm just explaining basically what the names are and what they mean. An EPIC is early postoperative intraperitoneal chemotherapy. This is, there's a port that's placed in during the surgery, and then this is chemotherapy that's given usually about 6 to 8 weeks after surgery. Moving on to systemic therapy. This is systemic means throughout your whole system. So your medical oncologist will choose the best therapy for you based on your staging, histology, and any identified mutations that you may have. So looking at systemic, this refers to things like chemotherapy, immune checkpoint inhibitors, which means for mesothelioma patients, basically immunotherapy, things like precision medicine, targeted therapies. So chemotherapy refers to cytotoxic, which stops the growth of rapidly dividing cells. And there are several types of chemotherapy, which will be described later today. Immune checkpoint inhibitors, which is immunotherapy, and this uses your body's own immune system to harness or fight cancer. There's precision medicine, which is personalized medicine based on your tumor's morphology, and targeted therapies, which attack or target specific proteins on your cells. And that, again, is actually a type of precision medicine. Moving on to the types of systemic therapy, there's some terms you might also hear and wonder, like, what do these mean? Neoadjuvant means delivered before surgery. Or induction therapy. The goal of neoadjuvant is to make the main treatment, like surgery, more successful. So neoadjuvant chemotherapy or immunotherapy, is followed by surgery. The next word you might hear is adjuvant therapy. Adjuvant is given after surgery, and the goal is generally to reduce the reoccurrence of the disease. So you may have surgery followed by adjuvant chemotherapy or immunotherapy. So that goal would be to follow up any micrometastasis or little cells that may be remaining in your body after the surgery. So surgery followed by adjuvant chemotherapy. Multimodality treatment or combination therapy. An example would be chemo, surgery, and radiation, or chemo and IO. And when you hear the word IO, that also will refer to immunotherapy. And a lot of times in mesothelioma, it does require multimodality therapy. So, lines of therapy. Lines means how many treatment lines you've gotten. So 1L would be your first treatment mode that you've gotten. So the very first treatment line of systemic therapy would be 1L. Looking at radiation. I am not an expert at all in radiation, but I will go through skim over the surface of it. So there is external beam radiation therapy, which is a non-invasive radiation beam that treats a specific part of your body. And there's several types. There's proton beam therapy. This works by delivering a beam of protons to destroy and disrupt tumor cells. There's, you'll hear IGRT, which is image-guided radiation therapy. And this type works by using imaging scans for planning the radiation and the actual treatment. So each treatment, they're using some type of image to guide each treatment. Then there's IMRT, which is intensity modulated radiation therapy. This method delivers radiation in a customized way using computers to calculate and deliver a higher and more effective dose. These beams can be shaped to match the shape of the tumor and therefore spare some of the healthier cells. And then there's SBRT, which is stereotactic body radiation therapy. This is a very precise and more intense dose of radiation. And there's one type called cyber knife. There's another type you might hear, gamma knife. And those are the external beam. Then there's another type of treatment, tumor treating fields. Example of this could be Novacure, Optune. I believe we talked about this in our patient group yesterday a bit. This is the use of electric fields to exert forces to kill cancer. Some examples could be microwave ablation or high-frequency electric fields. Moving on to clinical trials. There's a lot of terms in clinical trials. Just going to go over a few. The objective, when you hear the objective of a clinical trial, what is that? That is the why. Why are we doing the trial? There's methodology. Methodology is how we execute the trial, how we carry it out. There's desired outcomes or endpoints. That's primary outcome. What is the most relevant answer to the research question? Then you'll see a bunch of initials, and you'll wonder, what are all these initials? The OS, PFS, ORR, CR, PR. So OS, overall survival, how long patients survive. PFS, how long patients survive until progression, progression-free survival. That's what that stands for. ORR, overall response rate. How long in total do patients respond? PR, partial response. Partial response means the cancer has shrunk but not disappeared. And then complete response. Sorry, I went out of order there. Complete response is we can't see the cancer anymore. Then we're looking at arms of a trial. You may hear that you got assigned to an arm of a trial. So participants are divided into specific arms or groups within a trial. There's a control arm and a treatment arm. So in a trial, if everybody got the same treatment, they wouldn't know if it worked or not. So they have to give what they call a comparator arm or control arm and a treatment arm, where they give some people one treatment and the usual treatment and then the trial treatment. And then they do it under very controlled, specific methods to see if the treatment arm worked better than the control arm, which is the usual treatment, to see which is more effective. And people a lot of times ask about placebos. It's not ethical to give someone a placebo. We don't give placebos without people knowing. The only time there'll be a placebo is if it's given in combination with standard of care treatment or given with another drug. But people, they don't do this anymore, where people are given placebos without their knowledge. So moving on, there's randomization. If you hear the word randomized, this is where people are divided into groups by chance. This is used through a computerized system usually. This prevents bias. This is why this is done. It also allows for this to happen where we have people in each group and they're divided evenly and fairly. Sometimes they are blinded. Blinded means that specific groups of people, usually the research team does not know what the patient is getting. They can be unblinded if there's an emergency case or they need to know for health reasons. If there's a severe side effect, we can find out if they're unblinded. Non-randomized is where you're specifically put into a group based on a specific mutation, or you go into categories based on your type of cancer. So that's where you know exactly where you're going in advance. There's 4 phases of a clinical trial, phases 1 through 4. Phase 1 is where we evaluate the safety and the tolerability of a drug. Phase 2 is where we're looking at the effectiveness and the safety, again, of the drug. Phase 3, we're often comparing the effectiveness against the standard care drug. And phase 4 is sometimes called post-marketing. This is where the drug has already been approved, usually by the FDA, and we're evaluating it in real life. Long-term effects, maybe some rare side effects, effects like with food studies, how things interact with foods. So those are the 4 phases. Now we're just going to barely again look at genetics and mutations. There's a lot to this, and I'm leaving this to the experts, but I'm just going to name a few, scratch the surface here. There's germline and somatic mutations. Germline mutations occur in parents' reproductive cells. These mutations change in the genetic material that the child receives from the parent. This is a hereditary mutation. You inherit these germline mutations from either parent. And there's examples like BRCA1, BRCA2, Lynch syndrome, cystic fibrosis, but there's also regarding our patients, well, I'll move on. There's somatic mutations, and somatic are changes to a person's DNA that occurs after conception to any cell that isn't a germ cell. And these somatic mutations do not pass from parents to their children, and they're not hereditary, and they happen sporadically or randomly without the mutation existing in a person's family history, and they cannot pass. And I was going to say, with BAP1, they can be either germline or somatic. So it can get a little trickier, and I'm going to leave that to the people who are able to best describe that. So, next generation sequencing is where the testing that people do. There's Foundation 1, Guardant 360. These are some of the tests that people have done to find out if they have mutations. They can use blood, tissue, saliva samples, and these testing can lead to emerging treatment options or clinical trials where we find out. I think I've spoken to several people about this before, but a lot of there's something called actionable mutations. Sometimes people will have a mutation that is able to be used or is able to be harnessed, I guess, for a clinical trial, which is something that will be talked about later today. There's something called novel therapies, gene therapies, which I keep repeating, will be talked about later today. Novel therapies is personalized medicine, focuses on targeting tumor cells and sparing healthy cells. And gene therapy, treatment approach that alters a gene. There's emerging approaches that include immunotherapy, viral therapy, and gene transfer. And I don't know as we have much time for questions, but all of these things, like I said, will be talked about in detail by our esteemed doctors today, and I thank you.
Thank you, Julie. Our next presenter is Dr. Hetty Kindler with the University of Chicago. We've never met. Nice to meet you.
Hi.
Presenting on chemotherapy, immunotherapy, and combination therapies. So please welcome Dr. Kindler.